A 65-year-old man with a history of type 2 diabetes arrives in the emergency room. For the last 3 days, he's been battling generalized tiredness and a worsening, unexplained confusion. Even before the first physical exam, a microscopic crisis is unfolding inside his vessels. As fluid is stripped from his bloodstream, red blood cells are clumping together into a thick, slow-moving sludge. On screen is a standard 10-second ER assessment. His Glasgow Coma Scale score is a nearly normal 14, meaning his eyes are open and his motor responses are intact. But his blood sugar is severely elevated at 400 milligrams per deciliter. Despite the acute confusion, a quick physical exam shows absolutely no facial drooping, no slurred speech, and no unilateral motor weakness. The classic hallmarks of a stroke are completely absent. Faced with a disoriented diabetic patient and a massive glucose spike, the standard clinical assumption points straight to a hyperosmolar hyperglycemic state, or HHS, a severe metabolic emergency caused by runaway blood sugar. Treating this strictly as a metabolic crisis seems logical, but anchoring on that obvious number on the glucometer without further neurovascular imaging often masks a hidden structural lesion in the brain. When a patient presents with sudden cognitive decline, the emergency department has to systematically eliminate other immediate threats, primarily central nervous system infections like meningitis or encephalitis. The lab results quickly close that door. His white blood cell count is normal, his inflammatory markers are low, and he has no fever. We are left with profound confusion, but absolutely no localizing neurological signs. His reflexes, muscle tone, and cerebellar functions all test completely normal. This is where the diagnostic model has to expand. A severe systemic metabolic crisis acts as an extreme stressor that can tip a vulnerable, pre-existing structural defect in the brain into total failure. Because the standard metabolic panels and infection markers cannot fully account for this acute behavioral shift, the medical protocol dictates an immediate pivot. The patient needs to go into the MRI machine. The MRI stroke protocol reveals the true diagnosis: an acute left thalamic infarct. It's a small, highly localized lacunar stroke buried deep inside the brain. This forces a physiological question. How exactly does a systemic spike in blood sugar cause a localized physical blood clot in cerebral tissue? This diagram illustrates osmotic diuresis. When glucose levels reach extreme heights, the kidneys attempt to flush the excess sugar out in the urine. Because glucose is highly osmotic, those molecules pull massive amounts of water out of the bloodstream with them. This rapid fluid excretion leads to severe systemic dehydration. In a matter of days, the patient's total circulating blood volume drops significantly. As the water disappears, the remaining blood cells and proteins become highly concentrated. The blood's viscosity spikes, transforming normal plasma into a thick, sluggish fluid. When this hypercoagulable sludge attempts to pass through a cerebral microvessel that already suffers from pre-existing atherosclerotic narrowing, it simply cannot flow. The vessel clogs, and the tissue downstream dies. To reverse this thrombophilic state, the immediate required intervention isn't necessarily a blood thinner. Unless there is a strict contraindication, you have to rapidly administer intravenous fluids to rehydrate the vascular system and restore flow. This explains the clot, but it leaves a major clinical discrepancy. A patient with a confirmed brain infarct is sitting in the ER without the expected paralysis or aphasia. Look at this map of cerebral blood flow. Most classic strokes involve the middle cerebral artery, affecting the lateral motor and speech cortices. This stroke, however, occurred in the posterior cerebral artery territory, which feeds the deep internal structures at the base of the brain. Deep within this posterior region sits the thalamus. It functions as the brain's central sensory relay station. Almost every piece of sensory input from the body travels up the spinal cord, synapses directly inside the thalamus, and is then sorted and projected outward to the cerebral cortex for processing. Crucially, the medial region of the thalamus is tightly integrated with the ascending reticular activating system, or RAS, the neural network responsible for maintaining wakefulness and consciousness. When an infarct destroys this specific medial thalamic region, the RAS is severed. The brain's wakefulness engine stalls. The direct result is stupor, acute behavioral changes, and profound confusion. Even as they recover, the destruction of these pathways can lead to severe downstream complications. Patients often develop Thalamic Pain Syndrome, where the damaged sensory neurons misfire, causing intractable, burning pain on one side of the body. Because posterior circulation strokes present as a shift in behavior and consciousness rather than an overt mechanical failure, diagnosing them requires a high index of clinical suspicion. Once the stroke is unmasked and the clot's location is confirmed, the medical priorities shift instantly from diagnosis to tissue preservation. This visual represents the ischemic penumbra. At the center is the infarct core, dead tissue that cannot be saved. But it is surrounded by a halo of electrically silent, yet perfectly viable brain cells. This penumbra is surviving solely on a secondary network of collateral blood vessels, which are working overtime to deliver a faint trickle of oxygen from surrounding arteries. These tiny, fragile collaterals lack their normal driving pressure. They rely entirely on high systemic blood pressure from the rest of the body to force blood deep into the dying tissue. This is why immediately administering antihypertensive drugs to lower a patient's blood pressure prior to imaging is a catastrophic clinical error. It actively starves the penumbra. A sudden drop in vascular pressure removes the mechanical force keeping those collaterals open. The blood flow stops completely, and the salvageable penumbra rapidly dies. Unless the patient is a candidate for immediate chemical thrombolysis, emergency physicians practice permissive hypertension, allowing the blood pressure to remain abnormally high to ensure those collateral vessels keep pumping. Because brain tissue dies within minutes of ischemia, managing a stroke is governed by strict chronological benchmarks, a complete clinical evaluation under 60 minutes, and door-to-imaging time under 20. While an MRI is far superior at detecting small, deep infarcts, like a thalamic stroke, protocols often mandate a rapid CT scan first. It takes only minutes and instantly rules out a cerebral hemorrhage, determining if clot-busting drugs are safe to use. Throughout this timeline, airway protection is paramount. Strokes in the posterior circulation carry a uniquely high risk for dysphagia and aspiration, meaning the airway can become rapidly compromised as consciousness wanes. We also have to rapidly rule out mimics like hypoglycemia. But while extreme low blood sugar mimics a stroke by depriving brain cells of their primary fuel source, extreme high blood sugar causes an actual stroke by physically clogging the plumbing. Beating the clock and eliminating these physical mimics dictates the entire operational rhythm of emergency stroke protocols. The primary diagnostic trap in this case was the initial assumption. Seeing high blood sugar and delirium and treating it strictly as a metabolic malfunction misses the mechanical reality. Here is the exact physiological chain of events. Severe hyperglycemia initiates extreme dehydration. That systemic fluid loss causes localized cerebral hypoperfusion, ultimately resulting in a focal ischemic stroke. When an emergency patient presents with an acute, unexplained cognitive decline, you have to look past the glucometer reading and consider the structural integrity of the brain. Saving this patient relies on two counterintuitive actions: aggressively pumping intravenous fluids into a hypertensive patient to restore blood flow, and actively resisting the urge to immediately lower their high blood pressure. This thalamic infarct was the physical consequence of a body-wide failure, where blood glucose levels physically altered the viscosity of the bloodstream until flow to the brain became impossible.